this is a great question because this is something that a lot of my research focuses on, and I think there's been a lot of attention in the news and even among in the healthcare setting about this. So certainly the development of direct-acting antivirals has helped address one of the previously existing treatment barriers, which was a lack of an effective treatment. So now we have drugs that are very effective, that are very tolerable, and can cure over 9 in 10 people. So that has helped substantially change the approach that providers have in terms of whether they want to offer treatment or recommend treatment to their patients. So previously, when we just had interferon, we would recommend treatment or we would reserve treatment for patients who had advanced liver disease or where we felt that the benefit often outweighed the potential risks of these treatments. But now with these much more effective drugs, we're really starting to advocate for treating patients early in disease because we see substantial benefit both in terms of disease progression and survival. So that being said, what are the remaining barriers? Because there still are many. So I think the biggest one right now is just the sheer number of people who are unaware of their diagnosis. So, for example, there are estimated 3.5 million people in the U.S. who have chronic hepatitis C virus infection, and it's thought that about half are unaware of this diagnosis. The CDC's recent recommendation to one-time screening for all patients born between 1945 and 1965, the baby boomer generation, is anticipated to identify 800,000 additional cases of hepatitis C. So certainly this is something that we as providers need to focus on, which is thinking about hepatitis C in each of our patients and screening where appropriate so that we can start to identify these cases and then offer treatment. So I think what follows next in terms of another barrier is the linkage to care piece. So great, even if we're able to identify a lot of these patients who previously didn't know they had hepatitis C, how do we ensure that they get into care and retain them in care? This is particularly challenging if you think about the groups that are at highest risk or have the highest prevalence of hepatitis C. For example, injection drug users or veterans, people with HIV, have often traditionally been marginalized in our society. And so being able to reach out to them and bring them into care where we can offer counseling about these infections, ensure proper health care and prevention for a secondary transmission, I think remains challenging. There was some recent data showing that as of 2013, only about 15% of people with hepatitis C had ever received treatment for hepatitis C. So clearly there are major gaps in linking these people to care and offering them treatment. So now, all that being said, I think that really brings us to the challenge that's perhaps most frustrating to providers like myself, and that sort of revolves around this idea that we have these amazing drugs available now with direct-acting antivirals that are very effective and very well tolerable, but I can't guarantee that every patient that I want to treat can have access to these meds. And that's been driven by the huge costs surrounding these new medications. So initially, when one of the first medications came out to the market, that was interferon sparing, meaning that it was all oral, one pill once a day. The market price for this was about $1,000 per pill. And so certainly, as a result of that huge cost, what we saw was almost unprecedented. There were treatment guidelines and insurance plans. Rollout of drug coverage was shaped by the cost of these medications. So we saw a prioritization of groups that should receive these medications, trying to focus specifically on those who had the most advanced disease or who had other comorbidities like chronic kidney disease and thus should be treated. Fortunately, as more medications and regimens have come to market, we've seen changes in the guidelines. We've also seen some cost-effectiveness data showing us that early treatment can be cost-effective, preventing a lot of the later-term complications that are more costly down the road, such as hepatocellular carcinoma or liver transplantation. And we're also seeing And as we're building the pool of patients who've been successfully treated, we're seeing that there truly are benefits to early treatment, and eradicating the virus in these patients. So I think the hope is that with the increased availability of newer agents and garnering more data to show that these medications are cost-effective and have clear survival benefits for these patients, we'll start to see the cost discussion turn the corner and not be as important of an issue.